see electronic case reporting in action. Each day, we are seeing around 25,000 electronic case reports for COVID-19 being delivered for 2 public health agencies from over 9,300 facilities that are live with ECR. Let us show you how it works. The surveillance of health conditions in living people is a core public health function. This surveillance allows for the monitoring, management, and control of conditions in the community. The reporting of conditions by healthcare providers to public health is required by law in all U.S. states and territories. When this reporting occurs now, the provider must identify that a patient has a condition that is reportable, determine which public health agency to report to, and then submit case reports manually. Jurisdictions commonly have 200 or more reportable conditions. Electronic case reporting moves the now primarily paper-based process to the automated generation and transmission of case reports from EHRs to public health agencies for review and action. The benefits of this automated reporting for both healthcare and public health include reduced reporting burden, enhanced communication between public health and healthcare, more complete and timely reporting, and use of a shared service infrastructure that supports this interoperability. The illustration on this slide depicts the high-level ECR elements. These elements operate using a shared service infrastructure with standards and technology that are operational in healthcare now. The demonstration will now step through the components for Dwayne as he seeks care for an illness. We will start with the documentation of care by his provider in the EHR. In this demo, we will have Epic and the Washington State Department of Health and partner Inductive Health. If you stick around for the next demo, you can see Cerner and Florida Department of Health in action as well.
All right, let's jump over to Epic. All right, so today we're talking about Dwayne Caldwell, who's a 56-year-old man who lives in Washington State. Dwayne visits his PCP for an urgent care visit because he's been experiencing a fever, loss of taste, headache, and general malaise for 3 days. On intake, his physician notes that Dwayne works as a grocery store clerk and is therefore an essential frontline worker relative to the COVID-19 pandemic. His physician enters a rapid COVID-19 PCR test that can be quickly resulted at an in-house lab. I'll go ahead and enter that order now. The test has resulted and Dwayne is positive for COVID-19. I'll document that positive result now. Based on this positive result, Dwayne's physician will document a visit diagnosis of COVID-19 as well as add it to Dwayne's problem list in his chart. I'll go ahead and document that now as well. The act of adding COVID-19 to Dwayne's problem list automatically triggers an electronic case report out to the Ames platform that includes Dwayne's demographic information and other pertinent information from his chart. This happens without any further input or action taken from the provider. Next, we'll hear from the Ames platform on how they handle evaluation and routing of electronic case reports to the appropriate public health entity. Back to you, Ames.
The Ames Platform is where the interoperability happens. The platform connects to healthcare organizations through networks like eHealth Exchange, Care Quality, and Commonwealth using Direct or XDR. For this demonstration, Ames is connected to Epic using Direct. The first thing we do with the eICR is to validate it for structure and for some necessary data elements. If the eICR is not valid, we will create a reportability response, or RR, with all the errors in it and send it back to the sender so they can fix it. One thing to note is that this process is not specific to Cerner or Epic because eICR is a standard that many EHRs are implementing. All the valid eICRs go to RCKMS for decision support. As mentioned, when COVID-19 was entered into the EHR, it matched the ICD-10 code for the problem list item and triggered reporting to public health. But this process is only the first of a two-step process. A more comprehensive evaluation confirms whether the case should be reported and to which public health agency or agencies. This is done by the Reportable Conditions Knowledge Management System, or RCKMS. RCKMS is a decision support service and knowledge management system that holds reporting logic for all public health jurisdictions across the country. RCKMS processes the eICR to determine whether it's reportable. RCKMS looks at the patient's residence address and the address of where the care was provided. In this scenario, both were in Washington, but could be different. The benefit of this model is for public health and for providers. That is, as it saves staff time across jurisdictional reporting, and it means cases don't fall through the cracks. RCKMS looks at jurisdictions' reporting logic. Each jurisdiction's reporting logic. In that, the second step of evaluating where the eICR should be sent, if anywhere. It compares the eICR, which includes the COVID-19 lab reporting results or problem list items, against the public health agency's logic and finds a match. RCKMS confirms that this is a reportable event of SARS-CoV-2, and in this example, an eICR should be sent to the Washington Department of Health. RCKMS sends the decision to Ames for inclusion in the reportability response, called the RR, along with any additional information from public health about the condition that is reportable, such as information about outbreaks, treatments, or testing that's available. This output also tells Ames where to send the eICR and the RR and what should be included in it. You will see how providers use the RR in just a minute. The RR also includes information that is relevant in the EHR system for EHR system administrators, such as errors, warnings, and other machine processable data. Once we have created the RR, we send a copy back to the healthcare provider. This happens 100% of the time. If the eICR is reportable, we send the eICR and a duplicate copy of the RR to the public health jurisdiction that it should go to. And remember, it could be more than one. For this use case, Ames and RCKMS provide a set of centralized resources that allow providers and public health departments to efficiently exchange data. Duplicating these will be very difficult and redundant. This saves both healthcare organizations and public health time and effort. They set up the one connection from each instance of their EHR versus connecting provider or clinic by clinic individually to each public health agency. This model of interoperability saves us all time and effort. Now I'll pass it back to Washington Department of Health.
All right, we'll jump in here and do a real quick showing what the reportability response looks like in the Epic system. So when we receive that reportability response back from the Ames platform, that's immediately visible to the provider in the patient's chart. So I'll click over there now. This also can be used to inform an infection preventionist work list full of positive cases that require follow-up to complete documentation, so they can follow up with the appropriate public health jurisdiction to complete that process. In this case, you can see the reportability response we received indicates this was indeed SARS-CoV-2 and that it is reportable to the Washington Department of Health. And next, we'll hear from Washington Department of Health on what they do with the information they receive in that electronic case report.
So once Washington State receives Dwayne's eICR and RR from the Ames Platform, they are processed by an integration engine to get into the state's disease management system database, which serves all local health jurisdictions and is critical for enabling our public health responses like contact tracing, symptom monitoring, and anonymous exposure notifications. This ECR shows Dwayne's occupation and is immediately useful for public health because they can prioritize essential workers for case investigations. The eICR format that is much richer for clinical data than traditional case reporting, which includes health equity data such as race, ethnicity, and language, shown there at the top of the case report, is invaluable for community engagement in public health responses. Digitally managing large volumes of case reports is absolutely necessary for incident management, like following up with Dwayne about his symptoms, his vaccination status, or possible contact exposures. It also helps by engaging Dwayne in participating in his own response to the incident by allowing him to use Sarah Alert on the left to help monitor his symptoms, and Washington Notify on the right to wirelessly and anonymously notify other possible people that may have been exposed by his infection. We think that encouraging the general public to participate in public health actions is absolutely necessary to improve our responses to all future emergency incidents. The COVID pandemic has really emphasized the need to digitize case reporting because of the sheer volume of case reports that public health agencies receive. Now that we are working together with our healthcare organization and electronic healthcare record partners, we are building out case reporting for all conditions, not just COVID. Washington State's investment and commitment to eICR has long-term value because it is infinitely adaptable as new determinants of health and responsiveness are identified. Such elements have already come up in the COVID response, like ventilator use, hospitalization types, and vaccine breakthrough infections. Since eICR removes the labor bottleneck of traditional case reporting of the huge volume that public health agencies receive, that allows us, in turn, to redeploy those resources to improve public health response, agility, and innovation. Now I'll pass it off to our partner, Inductive Health, to describe how they work with us.
Inductive Health has supported case management and investigation at public health agencies, including the Washington Department of Health, through delivery of electronic health messages throughout the COVID-19 pandemic. The Respond Point of Care application enables nursing homes, workplaces such as grocery stores, university student health centers, traditional clinical environments, and other sites to report robust health data, including demographic, clinical, Ask on Entry screening, and testing information directly to agency systems. When Dwayne gets tested for COVID-19, a record will be created at the point of care to be sent to the Washington Department of Health within 4 hours. The application can create XML and other data formats to support interoperability among agency systems, including eICR. It integrates with electronic disease surveillance systems, including Washington's surveillance system, the NEDS-based system, and EpiTrax for prompt delivery of critical data elements to support case investigation and follow-up. In addition, the application will send the patient's test result date and smartphone number to Washington Notify's API. Washington Notify will then anonymously notify anyone who has been near Dwayne within the last 2 weeks that they may have been exposed to COVID-19, driving individuals into the traditional clinical pipeline for screening and treatment. As a result, additional case data can be shared with public health agencies for analysis and intervention. Finally, we can integrate this application into surveillance systems as well as contact tracing applications to streamline workflows for epidemiologists and disease intervention specialists to conduct symptom monitoring via text, phone, or email outreach as part of case management. I will now turn it over to the eICR team to share more about the substantial impact eICR has had on the pandemic response.
All right, great. This graph is constructed from real-time COVID-19 electronic case report data, flowing from EHRs to public health agencies nationwide using the process you just saw. We were able to rapidly add reporting for COVID using ECR at the start of the pandemic for just under 200 facilities that had implemented ECR at that time. Since that time, we have added over 9,300 facilities using electronic case reporting for COVID-19 reporting. And as you can see, the graph is very clearly and accurately depicts the latest COVID-19 surge due to the Delta variant. In addition to the big picture, you can also see the day-to-day fluctuations in reporting numbers. Each report shared electronically contains the detailed case data that public health agencies need to help with this latest surge and with other challenges and outbreaks that are still to come. The Centers for Medicare and Medicaid Services has recognized the value of electronic case reporting and has made it a requirement in the Promoting Interoperability program for hospitals beginning in 2022. There's a similar rule out for comment now for community providers as well. While there have been many challenges in addressing COVID-19 pandemic, acceleration of implementation of ECR is one good thing that this pandemic response has brought. The burden of reporting has been significant on healthcare and public health, and accomplishing reporting by using electronic exchange of data that is captured in the EHR as part of care is a significant step in reducing the burden of manual reporting for all involved. Thank you all very much for joining.